Hello, my name is Allison Taylor, RN, and this is my BSN capstone presentation for Midwestern State University. Today I will be presenting evidence-based practice on donor human milk supplementation, a review of evidence-based practice on successful exclusive breastfeeding in the newborn nursery. Mothers who wish to breastfeed and not supplement with formula should have their wishes respected and advocated by the postpartum nurse. Caring for a newborn in the hospital means the nurse will have contact with families from all cultural backgrounds who have many different desires for how they wish to feed their newborn. Due to the multifaceted levels of care for couplets while inpatient, there can be many barriers to successful lactation establishment at the entry level. Stress, physical or emotional interruptions during breastfeeding attempts, as well as a lack of education on best practices regarding breastfeeding can be mitigated with increased coordination of care, increased education for staff and for patients. Postpartum units today should be using evidence-based practices to support current recommendations for breastfeeding use and for the use of donor human milk for supplementation, instead of commercial formulas to promote a successful breastfeeding journey. Families benefit immediately by receiving uninterrupted time to breastfeed and bond with the newborn. There is a rising trend of donor human milk use in hospitals for both healthy and vulnerable newborns and infants. Therefore, the casual use of commercial formulas must be critically assessed for true need rather than for immediate convenience. Donor human milk is a viable and integral solution to the promotion of public health establishments, public health improvements established by Healthy People 2030. Breastfeeding through the age of 6 months of life is linked to stronger immune systems in the infant and reduced health risks for the mother. Current baseline data from 2015 states that only 24.9% of infants were breastfed through the first 6 months of life in the United States, with a projected and hopeful growth of 42.4%. This feat will require a vast increase in staff and patient education and support in the hospital, as well as through the healthcare system to increase the exclusivity of breastfed infants. The rationale for this project is the purpose of this project is to educate the postpartum unit on evidence-based practices relating to the use of donor human milk for supplementation while promoting exclusive breastfeeding. The evaluation of barriers and ways to promote best practices will be the focus, with a proposal plan to challenge them. Having nurses who are resistant to change can be a challenge for implementing evidence-based practice. Another challenge can be with the providers or the administrators who are concerned that the cost of donor human milk will have a negative financial impact on the hospital. The problem statement, or PICO statement, is in neonates in the well nursery. How does donor human milk supplementation affect exclusive breastfeeding rates compared to formula for supplementation or no intervention during hospital admissions? The literature review for this project states, in regards to the importance of breastfeeding, researchers note this. Evidence-based protocols from organizations such as the American Academy of Breastfeeding Medicine provide detailed clinical guidance for management of specific issues, including the recommendations for frequent and unrestricted time for breastfeeding as to minimize hyperbilirubinemia and hypoglycemia. All right, these are two of the leading physiological disorders monitored in the newborn nursery while the patient is in the hospital setting. These can be directly mitigated by the frequent feedings of human milk by direct feeding from the mother or by bottle feeding donor human milk. Necrotizing enterocolitis is another disorder that neonates face that is influenced by the early intake of formula. The use of donor human milk was evaluated in a 2019 research project by Dr. Care, and it concluded that early limited volume supplementation with donor human milk is likely to have a significant favorable impact on breastfeeding outcomes. As a nurse, one of the many important responsibilities is patient education, and that patient education begins on admission. Teaching the family about the safe practice of using donor human milk and the many gut health benefits should the family need to supplement. This knowledge will help the family make an informed choice as to how they wish to feed their baby. However, the beneficial effects of donor human milk remain significant, and donor milk is still highly preferable in comparison to formula. Formula use in the first weeks of life contribute to breastfeeding failure. Pediatricians and nurses alike must remain vigilant in the care of the smallest patients who are unable to voice their pain. And this is when we're talking about things like necrotizing enterocolitis that can result from the early introduction of formula. Assessing the changes in breathing, digestion, and pain frequently can help diagnose problems sooner. The use of commercial formula products and assuming the physiologic process will be the same causes certain risks to rise. A mother's own milk improves growth and neurodevelopment, decreases the risk of necrotizing enterocolitis and late onset sepsis, and should be the primary enteral diet for premature infants. Donor milk is a resource for premature infants whose mothers are unable to provide an adequate supply of their own milk. To me, this information is incredibly dispelling of the argument that formula has merit in disease prevention. The lack of longitudinal studies regarding the impact that donor human milk has on the health of an infant through the first year of life is marked by several other studies indicating that the current evidence of donor human milk use in populations other than preterm infants is limited by lack of direct health measures and infrequent use in randomized trials. All right, so the proposal and the plan. First-time mothers and women with cultural sensitivities regarding privacy are the primary stakeholders of the changes proposed. The policies regarding increased privacy and the use of donor milk supplementation to lessen maternal and infant stress if lactation is delayed or impossible should be universal. There is a definite cost effectiveness for families if they can exclusively breastfeed. For the infant, many metabolic and physiologic disorders are prevented by the consumption of human milk. Formula is an inferior food than human milk, straight from the mother or carefully vetted and prepared from a donor milk bank, should only be indicated for use if there is a proven emergent medical need. It is my belief that donor human milk should be the supplement of choice within the clinical setting. In first-time mothers, the use of formula while inpatient leads directly to breastfeeding cessation in mothers who intended to exclusively breastfeed. Continued education and yearly training on providing bundled care with the rationale should be encouraged in all women's services departments, and the staff need to be educated on these practices. A tour of a local milk bank and educational seminar presented should be viewed by the nursing staff as well. A true understanding of how the processing of human milk before it is released to recipients is important to educate patients and their families and to obtain true informed consent. Clinical workers in and outside of women's services on the meaning of different plain text signs and what to do if they are in place. So these are some of the things that we are wanting to implement to increase that bonding time and uninterrupted breastfeeding time with the mothers. So in the hospital setting, you have a lot of interruptions from dietary, from environmental services, from the social worker, from admissions, from the providers. And we want to just try to cluster the care, if at all possible, on certain tasks, and then have those signs available, letting the person know, please knock, or if it can wait, let it wait so that mom can have uninterrupted time. All right, so postpartum mothers should be educated to notify the nurse of periods of breastfeeding so signs can be hung. And then a trusting relationship between the nurse and the patient can increase the communication between both and lead to excellent patient-centered, culturally competent care. All right, the education need. We've talked some about educating your staff and the families. So women should be educated about the donor human milk screening process and encouraged to request if there's a concern about a delay in the establishment of the mother's lactation. Nurses should learn about the different ways to support women and methods to prevent interruptions. Administrators should learn how cost-effective 100 milliliter vial of human milk is in comparison to formula supplementation. The size of the healthcare facility would not be as great as a factor since human milk has a long shelf life, 1 year in a deep frozen state, and barriers or limitations to implementation. So the coordination of care between all hospital entities is a difficult task since this includes the custodial services, which I've talked about, dietary services, and all of the different employees who are going to be coming into that mama's room. So we're going to work on clustering the care. Our successful establishment of proper latch and maternal bonding, uninterrupted time to nurse in private. And then as far as our data collection, prior to discharge, women should be asked whether they felt they had enough uninterrupted time to establish breastfeeding and felt supported enough to ask for donor milk if a true deficit existed. At a 2-week checkup, the pediatrician would reinforce breastfeeding education, follow up with any concerns, and evaluate the newborn's growth. Also noting weekly evaluations of formula and donor milk used for supplementation in the hospital setting. And then barriers and limitations to evaluating the outcomes. Longitudinal studies require vast amounts of time and resources to measure success. And these can be tracked by having a staff nurse in the postpartum unit making phone calls to the mom and following up at the 2-week mark, the 4-week mark, 6-week, and then at 3 months and 6 months, just to follow up. And then logs will be kept with that information. All right, so also when we're talking about educating the staff, we would be implementing CEUs for those education days when the staff would be in a classroom learning about how the program would be implemented. The expert in the field that I interviewed for this project is Amy Vickers, and Amy Vickers is the director of the Mother's Milk Bank of North Texas. She holds a Master's of Science in Nursing Leadership. She is also an international board certified lactation consultant and has been the director of the Mother's Milk Bank since 2004. So she definitely is an expert in her field. She stated that many of the bigger hospitals do use donor human milk in the newborn nursery for supplementation. They also offer milk to go, and milk to go is where the family purchases 200 milliliters of milk for the fee of $20, and that is what is considered 48 hours worth of supplementation just to help until the mother's milk is established. This is going to be something that they're hoping ultimately insurance would pay for. Right now, it's just going to be on a cash-only basis. Let's see here. In summary, the current saying of fed is best is true. in that the nurse must be respectful of how the patient chooses to feed their infant. For the mother who desires to breastfeed, having the nurses teach and continually educate of the options in their facility is an example of being an advocate by teaching and informing. As a postpartum nurse myself, it's my intention with this project to present this information to my unit director and to my manager in hopes of having the current policy updated. So we do not currently use donor human milk for supplementation in the newborn nursery, and that was my hope and focus with this project, is to implement change. Education programs for healthcare providers are needed to improve knowledge and education of donor human milk, the benefits and the safety, to provide guidance to the parents. And it is crucial to develop legislation expanding the insurance coverage to achieve donor human milk reimbursement for those families that are wishing to use that. So thank you for watching my presentation. I look forward to answering your questions. Donor human milk is very near and dear to my heart. I have twins who received donor human milk while in the hospital, and it is something that I'm very passionate about. And I think that that is a choice that women should be able to make if that is something that they're wanting for their children. So good luck to everybody. Thank you.